Everyone, this is Poonam Sagar at Indoindians.com, and today we have a health talk. And we are very pleased to have with us Dr. Saurabh Rastogi, who's a cardiologist at the Gleneagles Hospital with the Noble Heart Center in Singapore. His subspecialty is in interventional cardiology for the treatment of coronary artery disease. He has practiced medicine for more than 15 years. His clinical expertise includes complex coronary angioplasty, stenting, intracoronary imaging, and hemodynamic assessment. And he also manages advanced heart failure. So prior to joining Gleneagles, Dr. Rastogi practiced at Neng Teng Phong General Hospital in Singapore. He is incredibly capable. He's a great doctor, and he shares his knowledge very generously and passionately. Welcome, Saurabh. Welcome to us, to Indo-Indians, and to share your knowledge with us.
Thanks, Moran. Thanks for the kind introduction, and welcome everyone who's decided to take some time off on a Sunday evening to join. Not.
Yeah.
So I'm going to kind of share with you guys a few things which I think are important concepts, and people keep talking about it, and just want to put them in perspective. So without wasting too much time, let me get to my slide deck.
Just a minute. Let me make you our co-host, and so you can share. Yeah, there you go. Have a health talk.
Okay, it's there?
Yes, we can see your screen.
Okay. All right.
You need to do presenter mode, please.
Yeah.
Okay.
All right. So I think, many a times we only start thinking about heart disease if you see a celebrity post, online or in the newspapers about some Bollywood actor who, had a heart attack or had a cardiac arrest. And that's when people start thinking, wow, he was so young, have access to all the healthcare facilities, yet, they were faced with such an unfortunate event, and how did it happen?
Yes.
And it always leads to a lot of questions. People talk, try to understand, and so my aim today is try to answer why this happens, and how a lot of advancement have happened in science that we can actually prevent a lot of these if we take the steps at the right time. So I'm going to take the next 30 minutes or so to kind of walk you through some basic concepts. So with that, I'll enter my talk, which is basically, can we prevent heart attacks? The ability to identify the risk before it's too late. Disclosures: I am an interventional cardiologist in private practice in Singapore, so be careful of any commercial bias you might find in my talk. So I'll start with a personal story of mine. This is my grandfather. He basically had a heart attack when he was 70 years of age. He was standing at a railway platform and he just fainted. He had no chest pains, nothing. They did some investigations and they figured out he had, many blockages. So he had an open heart surgery at 70 years of age. He's a doctor by profession. He continued to work. He got a stent when he was 90 years of age. After that, he became the oldest practicing doctor in India at 100. He was inducted in the Limca Book of Records as the oldest practicing doctor. Some of us, who are from India may be familiar with that. And he passed away at the age of 103. So when he had his open heart at 70, I was in a boarding school in India, must be in grade 5. And, I came for my winter break. My parents told me, and, I tried to understand what it was. But because he had it, I actually made a project about it at that time saying, know your heart. And ever since then, it kind of stuck to me that, maybe this is what I want to do when I grow up. And that led me to my own personal journey. I did my grade 12 from DPS in Delhi, went on to do medical school at Maulana Azad in Delhi too. Moved to the US, did my training in medicine, cardiology, interventional cardiology, practiced there for a few years. And then life brought me back to Asia for personal reasons. I moved to Singapore in 2015, was in the government hospital for about 7 years. And then 2022, I came to Gleneagles, and I've been practicing here for the last 2 years under the Noble Heart Center. So that's a little bit about myself. So I'm going to start first with just an animation video. This is about 1.5 minutes of just a cartoon video of what is, your heart, arteries, and what's a heart attack. And then I'll, dive down into the concepts after you hear this. So just listen to this for the next 1.5 minutes.
The heart is the primary organ of the cardiovascular system. It is a beating muscle that continually pumps blood to the rest of the body. The coronary arteries supply the heart itself with the necessary oxygen and nutrients it needs to function effectively. Red blood cells, white blood cells, and other substances flow freely to the heart and other parts of the body. In a healthy person, the walls of the artery are smooth and uniform in thickness. Over time, however, a high level of circulating cholesterol can cause fatty deposits called plaque to accumulate. As plaque is deposited, it can harden and cause the artery to become narrowed and less flexible, a condition called atherosclerosis. If atherosclerosis develops in the coronary arteries, the condition is called coronary artery disease, or CAD. If blood flow is severely interrupted, a myocardial infarction can occur. A myocardial infarction, or MI, is another term for heart attack. If blockage of a coronary artery exceeds 70%, the risk is increased for experiencing a heart attack. The risk is almost certain when plaque completely blocks a coronary artery. Another way CAD can increase the risk for an MI is by the development of a blood clot. Oftentimes, a crack can develop at the site of plaque buildup. When this happens, blood can coagulate or clump together at the site of the crack, or a blood clot, called a thrombus, can grow in size until it completely blocks blood flow. The extent of damage sustained by the heart during an MI depends on the severity and location of the blockage, and the speed at which medical treatment is received. Fortunately, there are many ways to prevent atherosclerosis and to lower the risk for developing a heart attack.
Okay, so I hope that was a short but a nice overview of it. So now I'm just going to dive down. So what is heart disease? What is coronary artery disease? Like the video showed, is basically you got to think of your heart as an engine, and it's got three fuel pipes, three main arteries which supply the blood. So if you develop any blockages, what we call plaque. So I'll be referring to blockages as plaque, which is basically cholesterol deposits in your arteries, which over time narrow the arteries and compromise the blood flow. So that's coronary artery disease. Heart attack is basically complete blockage or near blockage of the arteries with this plaque, which causes damage to the heart muscle or the engine, and sometimes it can be fatal. So this is a true picture of the arteries of a heart, which I'll show you more later on. But essentially, when an artery completely occludes, this is what it looks like on an angiogram. That's what we do. And when you open it with stents, that's what it looks like. So you hear both these terms normally. You hear heart attack and cardiac arrest, and they're two different things. So heart attack is basically blockage of the artery. A cardiac arrest is when your heart stops pumping blood. So one's the electrical problem, one the plumbing. But basically, when a blockage happens, it can cause the heart to stop pumping, and that's a cardiac arrest and sudden death, as you have often heard when people, mention the word cardiac arrest. So I'll give you an example. I had this patient who actually had seen me, generally a middle-aged gentleman, had recently moved from the US, very fit, no problems. He had come to the emergency room with chest pains. And when he arrived, he was in what we call normal heart rhythm. But within no time, he had a cardiac arrest. And this is what happens to your heart rhythm. Your heart basically stops beating, and it goes into this thing called fibrillation, where it's just fibrillating and it's not pumping. And that's what's actually a cardiac arrest. When we took him for an urgent angiogram, this is where the blockage was, and that's after opening it up. And I'll show you a real picture of it. This is what it looks like on a moving picture. Your arteries blocked off like the animation video with a blood clot. So the circulation to that muscle stops. And what we do in the procedure is basically open it up with a stent and restore the blood flow to the muscle. Just because his blood supply had stopped to such a large area of his muscle, his body reacted with the pump just shutting down and goes into cardiac arrest. And had he been at home with such an event, he probably would not have made it. And that's what happens quite often when you hear people pass away in their sleep or had chest pain at home and died. And this is the mechanism by which things happen. Now, what's the journey of the plaque? It starts as this little streak in your arteries on the inner surface, this cholesterol LDL that you've quite often heard when you do your blood test. It starts depositing in the arteries. And over time, it gradually grows. The growth is dependent on the cholesterol levels, other risk factors you may have, which we'll talk about later. And then it reaches considerable sizes, like the video showed, and sometimes it can rupture. This rupturing of it is the nidus for clot formation and so called acute heart attack when the complete blood supply shuts off. And like I said, the central to this plaque deposition is this particle with the bad cholesterol, so called LDL, and some amount of triglycerides, which contribute to this plaque formation. Now,
Saurabh, can I interrupt and can I ask you, what is the primary signs that somebody is having a heart attack or has a heart problem?
So that's a very good question. And the issue is that there is a classic teaching or symptom you'll say where a patient will feel like there's an elephant sitting on his chest, like really bad chest pains, going down his arm, sweating. It feels like doomsday. But there are very few people who actually experience that. A lot of people, I've had someone come to me feeling that he's had some acidity for the last one day. Just came to see for that. Some people just feel weak, especially elderly people just get confused. So, and a lot of times, most of the time, what happens, people think it's acidity. They'll sit on it for a few days until things start getting worse. Sometimes it takes time.
Right.
But yes, the classic symptom is this, doomsday chest pain, sweating, which, when it happens, people will know it. But unfortunately, like I said, they've done studies and say 30% people have classic symptoms, 30 will have some vague symptoms, and 30% just have silent. That's what you call a silent heart attack.
Right.
So it's a mixed bag.
Okay.
Yeah.
Continue.
So this high cholesterol is just one piece of the puzzle that increases the risk of plaque deposition. Apart from that, you have all these conditions which your doctors would have spoken to you about over time: diabetes, blood pressure, smoking, kidney disease, family history, sleep apnea, chronic inflammatory conditions, poor exercise, bad diet, overweight. They all come together and they all increase the risk. So in this next slide, I'm going to try to explain to you exactly what happens. And this is the core slide. If everyone understands this, everything else will make sense after this. So like I just showed you all the various risk factors that increase the risk of plaque deposition. How do they do that? Essentially, all of them in some manner, and these are complex ways which we don't have exact understanding, but they will increase the inflammation in your body. That inflammation leads to something called endothelial dysfunction, and that promotes atherothrombosis or atherosclerosis, which is the whole concept of plaque deposition. Now, let me show you how that happens. In the earlier slides, I showed you how this yellow stuff, which is the plaque, starts depositing in the arteries. This is the magnified version of it. This is the artery wall. This yellow stuff is equal to the plaque, and this is the lumen of the wall. I'm going to try to make it in a layman's term for you to better understand. So these LDL particles, you see, think of them as immigrants. The vessel wall inside the artery, think of it as Mexico. The actual wall of the artery, the muscle, think it's the US. And this pink lining is the Trump wall, the wall between Mexico and the US. Okay. Now this endothelial lining or the wall is the key central part for plaque deposition. Now imagine if you have too many immigrants, that's called like high LDL cholesterol. They can overpower the wall and leak into the artery. And once they leak into the artery, the chemical reactions happen that start this whole process of plaque deposition. Sometimes you can have just normal amount of LDL particles, not too high, but there's weakening of the wall, which is endothelial dysfunction. And this can be caused by any of these things, from unhealthy lifestyle to environmental stresses, mental stress, you name it. All these things can all center down to something called endothelial dysfunction and lead to plaque deposition. So a lot of times you see very healthy people who develop heart disease or heart attacks. You don't know the whole story. And you might say, wow, the LDL is normal. But normal also has a spectrum, and I'll show you that in the next few slides. But they could be having the so-called endothelial dysfunction for other reasons, which compromises the integrity of the wall. And then the particles enter the LDL and they cause this plaque deposition. Does that make sense?
Yeah, means we can see the Trump wall.
Okay, yeah, it's all about the Trump wall. So, and think of it, if you just try to lay it out like that, I think you'll better understand what's really happening in the arteries. Now, this is an interesting slide. There's this whole thing called global disease burden. It's a multinational group. It's got 10,000 researchers from 160 countries. They have database of millions of patients, and they essentially try to tell you, because you have to basically understand at the population level how is the disease happening, right? So this is Southeast Asia and South Asia, where maximum amount of heart disease is this pink line, which is the so-called heart disease related to blockages. Now, the more important part I want you to look at is the B section about the risk factors for developing these blockages: environmental, metabolic, and behavioral. So if you see environmental risk, whether it's pollution, house pollution from fuels, lead exposure, metabolic risk factors are the ones which you're commonly familiar with: blood pressure, high cholesterol, overweight, high glucose, kidney dysfunction. And behavioral risks are, poor diet, smoking. So all these things lead to increased risk of heart disease. And how do they do that? Is by the endothelial dysfunction pathway. That's how it all happens. So this is a study of about 4,000 people. They're just looking middle-aged, healthy people. They're longitudinally following, and even people who have excellent cholesterol. Okay, so this lower bar here is about your cholesterol level. I think a lot of you must have run your blood test, and they tell you that even if you're between 100 to 130 milligrams per deciliter, that's okay. But in reality, that may not be okay, because you see, even people with below 100, the stop line is the evidence of plaque in your arteries. Up to 30% of people below 100 LDL can still have plaque. And similarly for sugar, when you look at sugar control, it's a spectrum. You may be diabetic above 6.5, but even higher sugars promote to plaque deposition, and that's from endothelial dysfunction. So a lot of times, apparently healthy people can still be developing plaque silently, and this is for all the surprise heart attacks that we see and come to hear about. So now, having understood what are the risk factors, how it causes heart disease, now let's come to when you come to a doctor's office, right?
So,
This is what,
can I interrupt?
yeah.
So people should, even if they have no indication of heart disease, when should they go for their first heart checkup?
Good point. If you give me 10 minutes, you'll have the answer.
Okay.
Yeah. Okay. So if you look at this, this is what happens, right? If you go to the office, they talk to you about your risk factors for heart disease. They will calculate some risk scores. A very common test done is the treadmill test to see whether your heart is in a good condition or not. But the problem with all these scores is that they are basically surrogate markers of probability. I mean, people can have risk factors, you can still have disease or may not have disease. It's the best guess from the outside of what's really brewing inside. It's not absolute. By these risk scores, you really can't quantify stress or inflammation, which is a complex phenomena. And so most of the time, these risk scores are off target. So if I show you this was a study of 300,000 patients. The bigger the studies, the higher the power of evidence that we have, whether we should use something or not. So this is a very common risk score used. It's a US risk score. And the orange line is the predicted risk score for these patients to develop heart disease. And the actual development of heart disease in these patients was the blue bars. So there's a huge discordance. So sometimes you could be over treating patients who may not be at that high risk, but that's the whole problem of the sensitivity with these scores. So this gentleman whose case I'd shown you, he had just moved from the US 6 months ago, and he had a perfect health chit. He got a clean chit. His LDL is around 100. He exercises, and he had all the regular normal tests and told he's in good health. So one of the tests they do is this treadmill test, right? I think a lot of you might be familiar where you go on the treadmill, they do a stress echo, nuclear stress test. Some of you may have heard these terms, some may not, but these are basically imaging tests to screen for blockages. And these full circles mean that these tests were positive, meaning that they indicate there's a blockage inside. But when you do an angiogram, which is the so-called gold standard of checking for blockages, less than 50% actually had a blockage, thereby meaning that, on an average, 1 in 3 of these test results could be false positive or negative. And the reason for that is that all these tests are, again, guessing from the outside what is happening inside, right? It's the inability to detect this plaque, the so-called cholesterol plaque, which is responsible for all the heart attacks. So I'll give you it's another example. I have a patient who I actually saw about 8, 9 years ago, and this actually really stuck with me. He was a 37-year-old guy. He basically came with some really atypical chest pain. Um, he could still run, but just pain off and on, no trigger, nothing classic of a heart attack. And he was a smoker, had hypertension, no family history, heart disease, and everything was normal except he had some chest wall tenderness. When you push on his chest, that pain would come on. It was like a very classic muscle pain. But we still did all the tests for him, all negative. He even went on the treadmill, was normal, no problem. So we reassured him, this is muscle pain, told him to, quit smoking, control his blood pressure. And basically 1 month later, he actually had a major heart attack. And, everyone like, how did this happen? And again, for the same reasons that these tests that we generally would be performing, they are just guessing what is on the inside. So this is the reality of heart disease. 50% who suffer a heart attack will do so without experiencing symptoms. 70% of people who have heart attacks are considered low risk by the traditional screening. And a lot of times, the minor blockages, which are missed by conventional stress testing, are responsible for heart attacks, like I just explained to you. So all these drawbacks are overcome by something called a CT coronary angiogram. This is becoming more and more prevalent. This is a technology where you can actually visualize the plaque. It's 90% accurate in plaque detection and estimating the severity of blockage. If
So
you can
everybody
see,
should do this rather
yes,
than the treadmill or the
yes,
angio.
yes. So, okay, just to answer in a gist, basically, if you're above 40 years of age as a male and above 50 as a female, you should strongly consider doing this, irrespective of symptoms. There are a lot of studies which are going on right now, taking asymptomatic people, and rather than doing the risk scores that we keep talking about, they start with a CT scan first. And I do this very, very aggressively, and I have lots of cases which I can show you, which will completely surprise you. So it actually is really the best test to do today to understand what's happening on your inside, despite the best living that you may be doing. Um, and it's very simple. It's not a like a tunnel like an MRI. It's like a half scanner. You literally are lying just the way these people are lying. Your head is out. It takes about 15 minutes. There's a small little IV plug put in your forearm, just like where they draw your blood. There's this iodine contrast which is injected, and that has it's the riskiest part of the procedure because it's like taking a new medication. But there's a very, very rare risk of some kidney injury or dye allergy. And the radiation in the CT scan is very little. It's about 5 millisievert, and all of us just have background radiation of about 2.5. And in fact, the new generation CT scans will be even lesser radiation. So all in all, it's a very safe test. And for the information it gives, the benefits completely outweigh the risks. Now, the CT scan has two components. One is the calcium score, and then one is the dye injection, the CT angiogram. So a lot of people talk about why can't we just do the calcium score? And you'll see a lot of literature around just do calcium score. It's very powerful, and it is powerful. A calcium score of 0 means you are at extremely low risk. And just to show you what calcium is, it's this white, chunks you see in the arteries. This is a clean artery, and then all these white things are calcium deposits. The higher the score, the more the risk of having a heart attack. And if you just do the calcium score, you don't have to put the dye in you, lesser radiation, but it has pitfalls. So the calcified part of the plaque is only 20%, and most of it is soft plaque, which is not picked up on just a calcium scan without the angiogram. And the reason is when the plaque deposits in the artery, it goes through a chemical process. The first half of that process, the plaque is soft, in which case the calcium score can be 0. And yet you can have a lot of this soft plaque. And if you take young patients, so if you're screening young people, right, 40, 50-year-olds, there's almost a 8 to 10% prevalence of having soft plaque with no calcium. So if you did just a calcium score, you may miss disease. And I'll show you a case example of it. But basically, a CT angiogram is the complete test. It covers all aspects. It picks up the plaque, which is your holy grail for heart attacks. So like, if you look at these pictures, the one on the left is a clean. So it's essentially the dye enters your arteries, which are like pipes. Just think of it as a pipe. And if it completely lights up, it's normal. And here on the right side, you see how the dye is lighting up the pipe, but you see this area where there's a lot of darkness and the whole white line becomes really narrow. Now that was a critical blockage. But this black stuff here is the soft plaque, which is non-calcified. And you see these white specks here, that's calcium. So this artery gives you a good example of the whole spectrum of disease from these calcified plaque and the soft plaque. Now this is a case where I had a 42-year-old lady. She came in really very atypical symptoms, some poking chest pain, very vague. And it was just like, as if, you could just tell her, don't worry about it. But she's had come a second time. So I said, okay, let's do some tests for you. She had an ECG and an ultrasound of the heart, which are all normal. She also had a calcium score, which was 0. But when we did the full scan with the angiogram, she had a critical blockage, 90%. So if you see it, here's the blockage, and that same blockage here on the angiogram that we do in the surgical suite, you can see how tight a blockage this was. So her artery was about to basically shut down. And this was a patient who came with just very, very atypical symptoms. And if you had not done this, the next time she may have presented with a heart attack, who knows? But that's the accuracy of a CT scan. So in summary, a CT scan is the most accurate way to have your cardiac risk assessment today. It picks up plaque, lets you know how much you have, and accordingly then, we can work backwards for risk assessment and management. So you were asking about how the data comes for why should we check asymptomatic people? So there have been lots of studies done. These are just two pretty famous studies where they took 25,000 sorry, can you hear me?
Yes, I can hear you.
Okay, I don't know. I got this thing saying the host has asked you to start your video. So
yes, because your video is switched off.
Oh, is it?
Yeah.
Okay, now?
Let me see. Yes, now I can see you.
Okay, sorry. So if you see, so this is, the whole justification of why should we do this in asymptomatic people, right? So these are studies there's one study of about 25,000 people, another of about 2,500, and they all are giving the same message that their silent heart disease is common. The plaque was found up to 40% people in both these patients, and patients with critical stenosis up to 5 or 6%. So again, same message, 2 studies.
So in your opinion, Saurabh, do you see this increasing because of the change in lifestyle, etc.? Do you think heart disease is increasing compared to, say, 20 years ago?
100%. 100%. There's no doubt. Except now my slides are not working. Can you see my slides?
I can see your slides, yes.
Okay. I'm just wondering what happened here because it's not moving.
We can start that again. Maybe you
can. Yeah. Now it's fine. Can you see? Okay.
Yes.
So if you see, this study was just published last year. Okay, and I just wanted to take a few seconds to listen to this. Same. They took asymptomatic people, about 10,000 of them. About 10,000 people, 40 years of age and older, not even 50 now. And again, this is what I tell all my patients, that if I took 100 patients, around 50% will have no problems. 36% had some disease, but it's non-obstructive. And then there'll be 10% who have very tight blockages. And these 10% over the next 3.5 years have an 8 times higher risk of having a heart attack than someone who has no disease or non-obstructive, right? And
Right.
so think about it, asymptomatic people who, the only time you come to hear about them is after a heart attack. But if you did these scans early on, you can know your own journey. So that's why this is helpful. So how does that happen? Why is someone who's got this plaque at a higher risk of a heart attack, right? I'll explain that a little bit. So like I showed you that the scan image before. So this yellow stuff, this dark black stuff is the so-called dangerous plaque. On the inside, this is what it looks like, where it has a lot of the soft plaque. So the more soft plaque you have, the higher risk of it rupturing and causing a heart attack. If you decrease the yellow stuff and make it more calcified, the plaque is more stable. So you will have disease, but your risk of heart attack will be lower. So CV risk as cardiovascular risk is lower. So the aim is, of course, the best thing you want is not to have any disease, but let's say you do have disease, right? The next step is how to decrease your risk of heart attack. That's the next question to answer. So that is where, statins are helpful. The cholesterol lowering medications, which we are all aware of, call it Lipitor, Crestor, Simvastatin. I think a lot of us may have heard about it. There's a lot of talk about these, statins. There's some fake news around it. But the way they work is basically they will decrease this so-called unstable plaque and make it more stable. And that way it decreases the risk of heart attacks. That's one mechanism of action of statins. The second, the so-called regression, is there. A lot of people ask this question that how can we eliminate the disease? You cannot cure the disease. But what you can do is stall the progression. And how you do that is if you drop your cholesterol very low, the number, your cholesterol number to 50, 60 or lower, in that case, this plaque growth decreases and also the plaque becomes more stable. And that's how statins help. Now, to give you perspective, this is a study which looked at people for 10 years, people with disease and without. So if you had a calcium score of between 1 to 100, which is a lower end, if you treated one out of every 100 patients you treated, you would say one heart attack, which is very, very impressive. And if your score is higher, for every 12 people you treat, you'll say one heart attack. So imagine you talk about millions and billions of people. How many lives can be saved with just this basic treatment? So it's very powerful. A lot of people question why not we take alternative statins, because statins have side effects, and which they do, small risk, but all these natural alternatives. They actually did a study. It's called the SPORT trial, where they took statins plus cinnamon, garlic, turmeric, red yeast, and nothing else drops your cholesterol or improves it as good as statins. So statins are very powerful in lowering your LDL cholesterol, which you will not get on a sustained level with any of these natural alternatives which people keep talking about. So to wrap it up, prevention based on detection of subclinical plaque, which is on CT, should lead to reduced heart attacks, as I've shown you all the evidence. So the current trend right now, what's the natural history of heart disease, right? People develop heart disease, they don't know about it, and then they have a heart attack. Once they have a heart attack, that's when you start treating people to decrease the risk of a second heart attack or preventing future problems. What we are proposing now is that you should detect early disease and then prevent it from progressing to lead to heart attacks, right? So that's how you can actually decrease your risk of developing heart attacks if you know your own state. So bottom line, prevention is better than cure. I hand out this table to all my patients. I have it as a leaflet that you have to be in the green zone to keep your risk low. Keep your inflammation low. That way, you decrease the risk of endothelial dysfunction. And if you see weight, diet, physical activity, stress levels, sleep hygiene, all these are very important to keep good endothelial function, decreased inflammation. And in our current urban lifestyle, it's very hard to keep this disciplined on a regular level. So, but that's what it takes. Medicines are complementary, they don't supplement healthy living. And then risk factors, like I said, are surrogate for disease. They are poor for risk stratification. Treadmill has limited accuracy, and early detection and treatment of plaque guided by CT angiogram does decrease your risk of heart attacks. So I'm going to circle back to my grandfather, and I can tell you, after his open heart surgery, I mean, for the last 30, 40 years, I remember, he was disciplined. The key here is discipline. He slept in time, adequate sleep, everyday exercise. 95% of the time, it was just home food. Very few times at some wedding or something, he would go out, but it was all home food. And, just good mental health. And day after day, year after year, that's it. Simple living and disciplined living. And he just went to the hospital 2 times, one time for his surgery, one time for the stent. And apart from that, he was on very few basic medications and did not really have any other problems. He led a good quality of life, even having heart disease, but he basically practiced healthy living. And that is extremely important. For him, pursuit of health was pursuit of happiness. And unless you start believing in healthy living, you will not be able to pursue it in a disciplined manner for life. And that's why we get into trouble.
Saurabh, yeah. So would you like to also share your few case studies, or shall we do a Q&A first?
I think we can do a Q&A. Let's see what people are thinking, what they would like to hear, and I mean,
so
the attention span.
You can stop sharing your screen so we can do a quick Q&A.
Yeah.
I'm sorry, can you go back to that slide again, the parameter slide?
You want to see the parameter slide?
Yeah. I'd like to take a screenshot.
Sure.
Take it on my mirror.
Yeah, no worries. Let me screen share. Yeah, this one?
Yeah, this one, correct. Thank you.
Yeah, no worries.
Also, Saurabh, your video is stopped. So you'll have to enable your video, your camera.
Cool. Yeah, it's on?
And screen share.
It's sharing now, right?
Yes.
All right.
You can stop screen share. I think Sunita has already taken a screenshot.
Okay.
Yes, perfect. So for everybody who's on this call, if you have any questions, if you raise your hands, you can talk directly with Saurabh and ask your question, or you could also just type it in the chat box and then we could answer that. So Saurabh, we hear very young people suddenly getting a heart attack. They have no symptoms. They eat. They're completely vegetarian. They don't smoke. They don't drink, and yet, suddenly you hear of people in their 40s getting a heart attack. So you explained to us that there are underlying factors and they should all be screening. But in your opinion, what could be the main reasons for things like these, for happenings like this?
I mean, like I said, it's a lifestyle thing, a lot of lifestyle, and then, and we may not realize. So genetics is one, which you can't exclude.
Yeah.
Like even with the best of lifestyle, I think that the devil is in the details. When you hear that someone is having the best lifestyle, you may not know all the factors that may be involved, right? Mental stress is a big one. There's a pure connection of stress with actually leading to, blockages development is a chemical process. So inadequate sleep. I have people, I can share cases of people who had no problems, but very stressful lifestyle, was sleeping less because of the work, targets to meet, anything, personal stress, professional stress, not sleeping right. It all affects your human body systems at different levels. And it can start creating that same endothelial dysfunction, which can promote plaque deposition. One thing I've commonly seen is that people come with this LDL of 130, 120, 140, and if you look at the lab's interpretation of it, it'll say it's near optimal, it's desirable. They'll put those words of reassurance, but actually it's not the case. You think about anything above 100 in general, and you accumulate it over the years. It's a cumulative exposure. And
Right.
I mean, I didn't talk about this right now, but they are now talking about, and it's a matter of time. They've taken people now from the age of 20 to 39, forget 40, and they're checking their LDL levels. And if your LDL is above 70, they're they're asking you to either take a medical intervention or just continue your normal life, and they'll see in 5 years
Mm.
whether you develop disease. So, they've done these studies on people who live in blue zones where people live to 100 years of age from, Japan to Italy, islands, the forests, and all their LDLs are actually in the range of 40 to 70, not even 100. And so, hence, there's this whole drive that, this what we think is normal is not really. And LDL is one thing. Then the second thing is blood pressure. That number 120, people say, 130, 140 chalta hai, it's okay. But cumulate that exposure over years, and it
Mm.
starts creating problem. Cumulate that glucose being pre-diabetic over years, sleep deprivation, stress, and so it's always accumulative. There's always a talk about this COVID which happened. COVID, like any other infection, can cause inflammation in your body, which again then leads to these heart problems. COVID has been sensationalized. You can have a normal pneumonia, you can have a flu, and all of those things can also create it, but no one talks about it. On social media, you'll hear one post and then you think everything is only that COVID thing, but it's more than that.
Talking of social media and Dr. Google, Saurabh, what is your opinion? There's so much information that is now blasted to us through social media, through WhatsApp, and if there's anything at all, the first place we go and look for is Google. In your opinion, as a medical professional, what would you advise people if they have any inklings, any symptoms? What should they do?
No, no. See, I don't know. It's very tough to make it generalized, but yes, I think if you have your family doctor whose opinion you trust, I think that's the best way to start, because he's able to put it in perspective. He knows you better to how to navigate next steps. But I tell people now that if they come for the vagus symptom, I still offer CT, because I say if it's clean, then for the next 5 years you can not worry and just don't, because you see all kinds of things, and these diagnostics are not available to us 10
Oh,
years ago,
yeah.
right? So in this day and age, why would you want to work with guesswork if you can know the absolute, and the risk for that test is very low, and the information you're getting is just phenomenal. It's very powerful.
Yeah.
Um,
Agree. Any questions? It seems to me that I'm the only person asking questions. So there was this WhatsApp where they asked about there's this concoction that you drink and all your heart plaque gets washed away. What is your opinion on that?
there's nothing like that exists. Nothing. Yeah.
Okay.
Yeah.
Doctor, I have heard that there's an injection going to come which is going to take away these plaques of the arteries. It will be soon there. What do you say on that?
That it's not taking away the plaque. I think if you're referring to the same injection, we already have it. It's an injection to reduce your cholesterol in place of statins. Where I don't know, is it the same injection you're talking about, which you take one every 6 months? Is that the
Yeah,
one?
yeah, that's every 6 months. That's right.
Yeah,
So
correct. It's called,
what is the role of that injection exactly? If I have patients who have
yeah, yeah.
heart
So,
ailments.
so its role is exactly the same as a cholesterol medicine, like we take a statin, right? It's
Yeah,
meant to lower your LDL cholesterol. That's the main function of that thing. And it's powerful in doing it, and you just have to take 2 injections a year. It drops it by 50%. And it doesn't, so you there is some theory that if you drop your LDL, like I was mentioning, below 70, or the lower you go, let's say 50, 40, some of this plaque will regress, but you can never eliminate the disease. And the
oh,
aim is whatever plaque you may have, you want to prevent it from getting worse. The
yeah,
bonus, if you drop your cholesterol low enough, some of it may regress, but the data on that is very, moderate evidence. So I don't like to lead people to this false reassurance. Oh, for sure, if your LDL level drops, you will definitely have no disease left. That's not the case.
that's
So,
not
but the point is, it's
okay.
the progress.
And doctor, what about when you do the ECG and echo and it says that the heart is working 65 between 65 to
Yeah,
75%. So
yeah.
that is the optimum?
Yes, that's the function. That's the pumping. I don't have a
Yeah,
picture right now, but that's the pump. Yes. So for heart function, the pumping is called the ejection fraction.
yeah.
When it fills blood, then it pumps it, and that's a standard number. So different labs, different clinics will have something between 55 to 65, some number, and that's a normal heart function.
Suppose, sir, if my patient who already had an heart attack and he goes and gets it done, and if it's showing 65%, what do you say? It is fair enough?
It's normal. Yeah. I mean, a lot of people get heart attack, but if they have a timely treatment, then the
Yeah,
muscle has not died. If the muscle has not died, then the function will generally be okay. So there are people who have critical blockages or even have heart attacks, and timely treatment. That's what the whole idea is, that time is muscle. When they say for heart attacks, the
yeah.
sooner you open up the artery, the more muscle you'll save, and the pump function will be preserved.
And sir, what does ballooning mean? Only ballooning, not putting a stent.
That so the I'm trying to see if I have some slide.
I recently had a patient who
Yeah,
who had a 80% blockage in one of the arteries.
yeah,
But when the doctor did the treatment, then only the ballooning did the work. There was no requirement for the stent. What do you have to say on such a thing?
yeah. So there is, so basically a stent. The main aim, the job of a stent is to keep that artery open.
Yes, sir.
Now, in the past, in early years, in the 80s and 90s, when they started doing ballooning, the
Yeah.
artery would collapse back, and that's why
Yes.
people have repeat heart attacks. Then they
Yeah.
came up with these stents, which are metals, which keeps them patent. Now, the reason the arteries remain open and the disease doesn't grow back inside is because there's a special drug on these stents.
Okay.
It's called, just think of it as a special drug that
Yeah.
keeps the artery from growing back into the stent.
Yeah.
Now, what happens is that now the technology is advanced where they can put this drug onto a balloon without the
Yes.
stent. So there's certain arteries, not all arteries, which are generally either small in size or where the operator feels that it may be reasonable to just apply the drug to the artery without putting the metal. And it has also got benefits because once you deliver the drug to the artery, it may not re-narrow. And so
Yeah.
it's called drug coated balloon.
I wanted to know about that only, where they say that there's only a 5% chance of the artery collapsing back.
Yeah. So
So,
that's the operator's discretion. It's a judgment of the doctor. But yes, there are certain situations where I do it very often,
yeah.
because ideally everyone wants no stent in the artery. If you can avoid metal permanently in the artery, why not?
Okay.
So that's the whole rationale. And so for these, especially for the smaller arteries, where if you put stents, there's a higher likely that they will fail in 3 to 5 years. If you
Mm.
can get away with just applying the drug and it does the job, then it's fine. So it's a subset of the arteries treated, which you can just do so-called this ballooning these days.
So, sir, if a person is leading the right lifestyle
Yeah.
and as per the food and the walking and everything is done, then, sir, does a person who already has an heart attack once
Hmm.
change the course of lifespan? The lifespan span gets shorter, or what have you to say on that?
No, I just showed my grandfather's case. He had a heart attack, he had an open heart, bypass surgery, stent, but he did these right things. He lived a really good, healthy life. And actually, it is, we talk about it as healthy life. They have done studies across millions of people
Yeah.
about living a healthy life. And if you check that green box I showed, there are actually 5% or less people who actually fall into the all the who tick box everything. So it's
Oh,
really easier said than done to practice healthy loving on a disciplined manner, day after day, year after year. Just how people go on these crash diets. They'll
yeah.
change the diet, they'll rebound, they'll change, they'll rebound, right? So that doesn't account for healthy living, because you've taken it as a chore or a mission, and after 3 months you say, oh, I practice, and then you start sliding back to your so-called happy spot.
Hmm.
Right? So your happy spot has to be a healthy happy spot. Otherwise, otherwise there'll always be that fight. And
Okay.
urban living today is all about fast food, experiences of restaurants, and all that is the opposite of what actually we should be doing. And so, if you talk about our grandparents' times, our parents' times, or people who live in smaller cities in India or anywhere else, in developing world, you don't have much restaurants. You don't have much of these things, right? People ate home cooked food, fresh food. One example I tell people is that, I mean, growing up, I had my first McDonald's when I was 18 years of age, when I came to med school in Delhi, and there was globalization happening in India, and my kid had his first McDonald's at the age of 2. You see the exposure of processed foods is starting so early today.